Okay, so today's topic is we'll start from idiopathic intracranial hypertension. So it is also called as the pseudomotor cerebri, right? Then there is increased intracranial pressure in it, right? But there are no obvious findings which are seen on the imaging. Okay, what are the risk factors for this idiopathic intracranial hypertension, like without any cause? So the risk factor can be summarized by this mnemonic: female toad, so female sex, then from toad tetracyclines if the patient is obese, having taken vitamin A access, and using this medicine danazol. Okay, so these are the risk factors, and this condition is also associated with a dural venous sinus stenosis, right? Then what are the findings? The patient presents with that he says that he or she says that she is experiencing headache, tinnitus, that is ringing in the ear, diplopia, that is double vision, right? And that usually arises from cranial nerve number 6 palsy. Right. Okay, the next one is there is no change in the mental status. Impaired optic nerve exoplasmic flow, that will lead to papilledema, that is raised pressure at the back of the eye. So there will be visual field testing. This lab test will show there is enlarged blind spot and peripheral constriction, right? The lumbar puncture of the patient when done will reveal increased opening pressure, and that provides temporary headache relief, right? Because obviously that in excess of the pressure is getting out. Treatment includes, obviously, for obesity there's weight loss, and the drug is acetazolamide, right? Invasive procedures for refractory cases are also some of the options. Okay, next the topic is hydrocephalus. There is increased CSF volume which would lead to ventricular dilatation, right? And ICP can be raised and cannot be raised as well. Then there are basically three types of this hydrocephalus: communicating, non-communicating, and hydrocephalus mimics. So in case of communicating, like everything, all the CSF is communicating with each other. Like it has got two types: communicating and normal pressure hydrocephalus. So in case of communicating, the CSF absorption by arachnoid granuli would be decreased. For example, arachnoid scarring after the patient has recovered from meningitis, right? And that is leading to increased ICP. Increased ICP, also papilledema and herniation features. Normal pressure hydrocephalus, what happens in this is that is basically a feature in older adults. It is idiopathic. CSF pressure is elevated only episodically, right? And there would be the triad of things, and that is because of the distortion of the corona radiata fibers because of the expansion of the ventricles. Okay, so the triad would include the gait apraxia, number one, that there would be magnetic gait, number two would be cognitive dysfunctioning, and number three, the patient complains of urinary incontinence, right? So wobbly, wacky, and wet, a mnemonic for it. So obviously the symptoms would get reversible by lumbar puncture or shunt placement, right? Non-communicating and obstructive hydrocephalus, what happens in that is there is no communication and there is an obstruction. So obstruction most commonly lies at the narrowest part, which is the stenosis of aqueduct of Sylvius, right? There would be blockage of CSF, because of which leads to non-communicating hydrocephalus. The third type is hydrocephalus mimics, that is ex vacu ventriculomegaly. Increased CSF imaging, increased CSF would be seen on imaging only, right? And it's basically due to the brain tissue atrophy, right? For example, in the conditions like I previously told in the previous video: Alzheimer's disease, advanced HIV, frontotemporal dementia, and Huntington's disease, right? So because of which that is only seen on imaging, right? The CSF would be raised while intracranial pressure would be normal. And also that triad which was seen above in the normal pressure hydrocephalus, that would also be not seen. Okay, so in the diagram you can actually appreciate these things, right? So the next one is multiple sclerosis. It's basically autoimmune inflammation and the CNS की demyelination. CNS में दोनों brain and spinal cords. Okay, the age is females, most commonly in between the ages of 20 to 40, right? And it is also more common in individuals who live farther from equator, like in those areas where sun exposure is less and vitamin D levels, serum vitamin D levels will be low, right? So basically the presentation would be any of among these. Optic neuritis, that is basically acute painful one side monoocular visual loss, right? And that is associated with RAPD, that is relative afferent pupillary defect, right? There could be the syndromes of brainstem and cerebellum, so lesions according to it, like diplopia, ataxia, scanning of the speech, intention tremors because of cerebellar disease or nystagmus, right? And the bilateral is more common than unilateral. Then comes there would be demyelination of pyramidal tracts. If that occurs, then there would be weakness and spasticity. If spinal cord syndromes occur, then the patient would experience electric shock like sensation along the cervical spine on the neck flexion, right? Also, other than that, the spinal cord lesions can cause neurogenic bladder, paraparesis, sensory manifestations affecting the trunk or one or more of the extremities, right? Okay. So these symptoms may get worsened when the person takes hot bath or he or she exercises because of the increase of the body temperature. The most common clinical courses are relapsing and remitting, right? The findings would be on the blood levels. IgG levels would be high, right? And the myelin basic protein in the CSF would also be high. MBP protein in the CNS would also be high. Oligoclonal bands are the diagnostic thing, and that basically comes in MCQ, that in the whole scenario oligoclonal bands are written. So you'll go for multiple sclerosis. MRI would be the gold standard test. Periventricular plaques would also be there, right? And other than that, the treatment would be obviously to stop those relapses and slow down the progression of the disease. We'll give disease modifying therapies, for example, like beta interferons, natalizumab, right? Okay. Treat acute flares. The acute condition or emergencies would be treated by IV steroids. The symptomatic therapy would be like for neurogenic bladder, you will catheterize the patient, muscarinic antagonists will be given, and botulinum toxin injection would be applied. And then for spasticity, baclofen or GABA B receptor agonists would be given, and for pain, you'll give tricyclic antidepressants or anticonvulsants, right? Anti-seizures therapy. Okay, so you can easily memorize this through this diagram. The multiple sclerosis, the features would be, ophthalmic features would be optic neuritis, diplopia, nystagmus, right? Neurological features would be the patient would feel fatigue, depression, ataxia, and intention tremors like cerebellum involvement. Speech dysarthria, scanning speech. The spinal cord, there will be sensory symptoms, there will be weakness, there will be spasticity, and down there will be urinary incontinence, right? So you need to remember like this. Okay, the next one is the demyelinating or dysmyelinating syndromes. So there are a couple of them. Number one is osmotic demyelination syndrome, right? It is also called a central pontine myelinosis. When you rapidly correct a patient with hyponatremia, right? So you will actually end up having this disease, right? Because there will be rapid shift of other osmolytes as well. That could also result in this. And what is the central pontine myelinosis? There will be massive axonal demyelination in the pontine white matter, right? Why? Because of the secondary rapid osmotic changes. Just I've told you an example of hyponatremia. So the patient can present with acute paralysis, dysarthria, dysphagia, diplopia, right? Loss of consciousness, and even locked-in syndrome, which I've already told you in previous videos. So this occurs because if you correct the serum sodium levels too fast, right? Like like you have to remember this mnemonic from low to high. Like if there's hyponatremia or any other solute is low, you go to high and you correct it. From low to high, your pons will die. Or this is an example of osmotic demyelination syndrome, which is this one. And from high to low, the opposite one, your brain will blow. Like the example is cerebral edema or herniation, right? You need to remember by like this. The next one is acute inflammatory demyelinating polyneuropathy, right? This is the most common subtype of GB syndrome, yeah, right? Guillain-Barré syndrome. Then this is also an autoimmune condition. Like which cells would be affected? The peripheral the peripheral nervous system, right? The cells are Schwann cells, right? Then they affect even the motor fibers, the sensory fibers, and also the peripheral nerves, like including the cranial nerve number 3 to 12. All the cranial nerves will be affected in this acute condition, right? Polyneuropathy it is, as the name indicates, and it is facilitated by molecular mimicry. This is the mechanism of action, and it is triggered by stress or inoculation. So this can come in MCQ, that molecular mimicry point, and the association with infections. No definitive causal link to any pathogen, no exact pathogen, but there would be association with infections, for example, Campylobacter jejuni and viruses like Zika virus. And this condition would result in symmetrical ascending muscle weakness or paralysis, right? It would be symmetrical, and that would be ascending, right? Okay. Then comes a facial paralysis plus respiratory failure. They both things are common. Autonomic dysregulation, which includes like cardiac irregularities, hypertension. Any one of these autonomic dysregulation. Or sensory abnormalities would also be there, right? Increased CSF protein and normal cell count. Now this is a typical feature of it, that is albuminocytological dissociation. Like albumin, that is a protein that is increased in the CSF. while doing lumbar puncture, while cytological means cell, the cell count would be normal, so it would be dissociation, right? Both things are going opposite way. Respiratory support is critical until recovery, right? And you give disease modifying therapies, plasma exchange or IV immunoglobulins, but there are no role of steroids. Then there is a thing which is acute disseminated post-infectious encephalomyelitis, right? This may be after any infection or vaccination. Then comes Charcot-Marie-Tooth disease. This is also called as hereditary motor and sensory neuropathy, right? It is an autosomal dominant disease, right? And you can remember this mnemonic CMT, say can't move toes. Okay, the lower extremity weakness or foot drop or sensory deficits out there, then pes cavus or hematos, all the things going down there, can't move toes, right? It's the most common type is CMT1A. It's not that important. Okay, so the next disease is progressive multifocal leukoencephalopathy, right? Now this is because of the destruction of the oligodendrocytes. Up there we studied about acute inflammatory demyelinating polyneuropathy. That was due to Schwann cells making PNS, peripheral nervous system. This is due to oligodendrocytes making central nervous system, right? Then it is also associated with severe immunosuppression, for example, lymphomas or leukemias. It is rapidly progressive. The areas included are the parietal and occipital ones, and visual symptoms are common. And increased risk is associated with natalizumab. So the other one, the previous one in the previous page, the disease we studied, that was basically treated with natalizumab, but this disease has got increased risk associated with increased natalizumab. Okay, then the other disorders, Graves' disease, metachromatic leukodystrophy, and adrenal leukodystrophy. These are just the names you need to remember a little bit, right? Okay, so next one is neurocutaneous disorders, right? A couple of them. Number one is Sturge-Weber syndrome, right? Okay, you need to remember some of the points among these now for MCQ point of view. Number one, this point, that the anomalies of neural crest derivatives. Okay, capillary vascular malformation would result in port wine stain, right? Port wine stain is important. Then cranial the trigeminal nerve ka V1 and V2 distribution are involved. That is why it is also called as the encephalotrigeminal angiomatosis, right? Because V1 and V2 are involved. Then these all things can lead to seizures, epilepsy, intellectual disability. You need to remember this episcleral hemangioma, right? That will lead to increased IOP and early onset glaucoma, right? Only these things are important in this disease. Then comes tuberous sclerosis. So it is an autosomal, almost all of them are autosomal dominant AD. So yes, with this point. And this TS, that is tuberous sclerosis, one thing that chromosome number 9 is involved, this you need to remember. Then hamartomas are seen in the CNS and skin, angiofibromas also. In tuberous sclerosis, there are a couple of things which you need to, have them in your consideration, like this mitral regurgitation association, angiofibromas, ash leaf spots, cardiac rhabdomyoma, right? Renal angiomyolipoma, right? And Sjogren patches. Okay, these are some of the points which, if come in a scenario, you will point your diagnosis towards tuberous sclerosis, right? Also, increased incidence of this giant cell astrocytomas and ungual fibromas. Okay, then come neurofibromatosis. This is somewhat important. Like, it has got two types, type 1 and type 2. Both are AD, autosomal dominant. Type 1 has got 100% penetrance and mutation in NF1 gene as type 1. So you need to remember chromosome numbers, right? In 1, the chromosome number is 17. How you will remember this? It as 17 letters are present in this. This disease has also the other name, which is von Reckling-Glossen disease, right? These spellings are of 17 letters, so you can remember 17 chromosome number, right? And the patient has got Café spores, intellect. So there is a mnemonic, CIC LOPS, right? So C, Café spots, I, intellectual disability, C, cutaneous neurofibromas, then L is basically leash nodules, right? Then comes the optic gliomas, P, pheochromocytoma, S, seizures, and then again S is the signs which are basically often from meningioma and some kind of bone lesions, right? Then comes the type 2. Type 2 has got NF2, and then that gene NF2 is also the tumor suppressor gene, and the other name is Merlin, right? The chromosome number is 22. So you need to remember that NF2 affects 2 ears, 2 eyes. So this is typically easy to understand. The 2 ears and 2 eyes for ear vestibular schwannomas, and for eyes cataracts. Okay, von Hippel-Lindau syndrome or disease. It is also AD, but you need to remember 3P, the chromosome number, right? And how you can remember is VHL, 3 letters. So chromosome number 3 is associated. Also associated with RCC, also has got 3 letters, renal cell carcinoma. Okay. And It is associated with a couple of diseases or benign and malignant tumors, which are remembered by HARP: hemangioblastoma, number 1, number 2 angiomatosis, number 3 is RCC, which is bilateral, number 4 is pheochromocytoma, like HARP. Okay, so these are the diseases which are called as neurocutaneous disorders. So I think till here it's sufficient for today. We will start from the next page by tomorrow, and I hope you got a good understanding of it. These are important for MCQ point of view, so you need to have a good grasp on it. This multiple sclerosis, it is very important, and this hydrocephalus topic is also quite important for MCQ point of view. Yes, okay, thank you so much. We will meet in the next video. I hope you like the video, and do subscribe and press the bell icon so that you can get my latest notifications. Also, you can check out my playlist whereby I have posted all the series. I have so far updated the cardiovascular series completely, the cardiovascular series including anatomy, physiology, pathology, pharmacology, right? And currently I am making the series for neurology, and it's almost completed, plus special senses are gonna be like soon. Okay, thank you so much for watching. Do share with your friends. Allah Hafiz.